Now, it's my pleasure to introduce Bernhard Wörmann, who is an oncologist, who is a medical director of the Medical Society of Hematology in Germany, and to his role from beginning on of the German AMNOG system. I think the hematology group took a very active role and said, okay, that's an area we need to be positioned, and we need to be very clear in terms of our contributions, in terms of our statements being involved in the process. And I think they were extremely successful and supportive in this one, and also beyond hemato-oncology, which I think is very important. We all know that 50% of assessments is in oncology, but it does reach far beyond. And the other, let's say, disciplines are often also even moderated or supported by the hemato-oncology team. So thanks very much for this long involvement in HTA, and thanks for joining this one.
Well, thank you very much, and thank you for inviting me. While I was sitting there during the previous talks, I had prepared 3 apologies. First, I'm the coffee break, which I'm not now. Second, I am not an HTA person, and I even discovered 2 flaws in my slides. I tried to change them, but this was technically difficult, so probably we won't find them anyway. And the third one is this is a national and not the large EU perspective, which you can see on the slides. On the left, well, in the middle is the Charité. On the left side is the German Society of Hematology and Medical Oncology. But on the right side, we have in Germany an association of all scientific medical societies, which are 180. And that's quite a strong political instrument to discuss with health politicians. This is just to impress you. That's the number of indications for new drugs which we have had access to in Germany in the past 12 years. So if you're fast, it's a little more than 180. And of course, for the clinician, most fortunately, we are happy that many of the clinical indications that we treat are covered. Unfortunately, some are still missing, like glioma. So this is a very basic slide, and this is not for you. This is for my colleagues. When we started with this process, we really had to explain them what this is all about. And when I now talk to other European countries, I get the feeling that we're doing exactly the same again. We still have to make clear that what we are doing with guidelines all the time is still looking at clinical benefit and the standard of treatment far beyond one single drug, but for indications, but also for diagnostic standards, and that what we had learned about, that safety and efficacy data are provided by the EMA, that the additional value which is provided by the value assessment, by the HTA process, is something which I really had to learn. In Germany, it only started 12 years ago, but it was considered something like a competition initially, that how can they affect our clinical decisions, and how can they affect approval of drugs? This is a slide which you certainly have seen before. This is a German process of the so-called AMNOG procedure. And when I initially, I think it was my first invitation was to Spain to explain the AMNOG procedure, and I just finished with the comment, this is German. It's very structured, but what's important is, if you look at the slide, I probably can show it here. We have a report on all new drugs, and usually it's provided by the IQWiC, and the medical societies in dark blue are fairly lately involved. They were only involved after the report and after all the previous quite significant determinations were done, like fixing the subgroups and fixing the comparator, and then we were allowed to discuss this. And of course, when we started to get involved, the critical question for the medical societies was, is it worth it? If it would have come out that all reports would have been identical to the final result, then we wouldn't have to have discussed. Then it would be nice to have. But when we looked after about 6 years, if there was a discrepancy between the report and the decision, which probably might have also been influenced by the medical societies, then at least in Germany, it was 30 to 40%. So about 1/3 of all decisions were different from the previous reports. And these are the main points of discussions that were provided by the medical societies. First, to inform at the time point that the comparator might have changed in between. And if you look at multiple myeloma, you heard it from Martin Kaiser, but also in DLBCL, the standard changes within 2 years. And it certainly is the case if you look at second and third line treatments. Second point, subgroups. Yes, we have formal subgroups, but as a medical society, we always try to involve clinicians that have also been involved in the clinical trials. That's difficult for you, for HTA person, because you always feel that there might be a conflict of interest. But if you have a clinician who treats a lot of DLBCLs, and he states that only 20% of his patients really qualified for the trial because there were exclusion criteria which he couldn't meet, that's quite an important information for us to see that probably the trial does not really cover the whole population, probably not even the central population which we are treating. Of course, endpoints is quite an important point. As we have seen it before, like the CTCAE scale of neuropathy does not reflect what the patient suffers. If you have a CTCA polyneuropathy of grade 2, it severely debilitates the patient, even if it's not grade 3. And those experiences or the ocular side effects that you have seen from all of the newer drugs are quite important. And probably the most important message that we got, we have completely changed our approach in Germany in the past 10 years. We changed from single experts to networks. If we do a comment now as part of the medical societies, we involved 3 to 15 experts per comment. That's a lot of work, but it really it really led to a change of kind of this culture of discussion. It's much more work to coordinate 15 experts because there are 16 opinions. But if you have done it for a while, and if you've really done it for a while, then you find it not only for hematology and oncology, but also in other networks. Most recently, we established a network for psychiatrists, maybe even the more complicated one, but they know that. But this is also something which I would like to discuss tomorrow. I think the reliance on single expert is not adequate anymore. We've certainly learned that even if it's more work, the result that we are getting at the end is much more stable if we have included all persons that were involved. In Germany specifically, we have medical oncologists, but we also have gynecologists who work in oncology. We have pneumologists who work on lung cancer. So we have to try to summarize them in one comment. This, I go over that, but this was quite important in Germany. In 2017, we started a formal cooperation with Nathan Czerny, and the Fries has already mentioned. I think we're one of the very earliest one. And this is now included in all comments. So in all comments that we're doing in Germany for the AMNOG procedure, we include the most recent MCVS evaluation. I can go over that. In Germany, this involvement of societies has led to a legal change. In 2019, they have decided that the medical societies now have to get involved already in the early consultation. This was quite a change. It was also something which was heavily discussed. And we now feel that most of it is positive. But these are the numbers from expertise that we are now getting in Germany. And that's a number for hematology oncology. And when it started in 2020, we had 111 consultations to be covered by the medical societies. And last year was about the same. And up to now, in September, we are again exactly at 111. So this is quite a way to organize it. But this is hematology. Oncology also covers non-malignant hematology. But you can imagine if we now discuss about hemophilia and early consultation about hemophilia, what is the best comparator in hemophilia? Is it still factor 8 or is it imizumab, for example? It's something which medical societies have to get involved in, but this is quite something which has to be organized. Can you jump over that? In Germany, oncology, but this is probably not correlated to our work. This is a comparison of the GBA decisions, giving no additional benefit, and the blue ones are all other non-hematological oncology approvals, drugs, and those are the oncology, and you see that usually oncology fares a little better than all the other drugs. Of course, discussing with my colleagues, I pretend that this is due to our involvement, but I'm certainly aware that this has more to do with the fact that oncology patients die and that we have overall survival as an endpoint, but it's quite a motivation for them. So the question that we are now dealing with is, also with the societies in Europe, is this our business or not, or is it too much work and is it really worth it? And I think we have three arguments. First, of course, as a physician, as a clinician, we want to have early access to new drugs. Patients read about it, patients learn about it, and if it's really something valuable, we want to have access. Second, which is probably for the future, we have to make sure that not only we have early access, but we have stability. And the last point is probably my most important point for the society. We don't want to have parallel worlds which are not connected. Patients don't understand it. If we have an approved drug, if we have a negative recommendation, for example, by the AMNOG, but if we have it in the guidelines, it's impossible to work that way. So we really have to do that together. At least that would be my conclusion. Thank you for your attention.